So I'm going to give you a few comments first to tell you what the goal is of this meeting. Is we've been together, all of us, whether you're a doctor like the two of us, or we've all been going through the epidemic of Lyme disease. And so that's why tonight, I've been working to try to do a survey, because I have so many patients who are in trouble. You know, what happens if I get COVID? Then others who are saying, well, what happens if I take the vaccine? And I even have more who just say, I'm not going to take it, at least not right now. And so, you know, we're all hearing through the internet, we're hearing through blogs, our friends, we're all making our own decisions. But it's this formal survey is intended to help us share our personal experiences. And so I wanted to talk about that, but I wanted to spend a little bit of time about this pandemic we're in. So I'm going to turn it over to Richard to have a few comments before we proceed.
Yeah, thanks, Dan. So first of all, there was a person on the chat who said they have no sound. Is everybody hearing Dan okay? And are you hearing me okay? You can just write something in the chat and just let us know. Okay. So, you know, I think this is a really important topic, and I'm glad that Dan did the survey and brought this up, because this is something, of course, I have patients ask me all the time, is what is the risk of getting COVID? What's the risk of the vaccine? And I just want to put this in perspective for you. So at this point, I've treated a little over 100 COVID patients, acute patients. I will tell you that I've had great success with the protocol we've been using, which is ivermectin 0.2 milligrams per kilo once a day for 14 days with glutathione and acetylcysteine, alpha lipoic acid. You can see what I've been doing on my website, cangetbetter.com, under the COVID tab. It's there for prevention and treatment. So first, know that I've had good success with the protocol, but here's, I think, where the problem lies. Not everyone is going to stay on prophylactic ivermectin. It was just published by Pierre Corey. There's 18 randomized trial right now on it. And you probably have to be on it twice a week for a very, very long period of time with things that will block NF-kappa B, which is one of the biochemical pathways with NAC, alpha lipoic acid glut. You can block the NLRP3 inflammasome, which is one of the pathways of inflammation with COVID, with melatonin. You can lower inflammation through NRF2 with curcumin and broccoli seed extract. There are ways of lowering down inflammation, but not everybody's going to take all these supplements every day, and not everybody's going to take prophylactic ivermectin. And I wrote to HHS a couple of days ago, actually, about this problem where patients are not going to get vaccinated. They're saying it's about 1 in 5 in the US that won't take the vaccine. And the problem right now, of course, is that I think there are studies showing that there are other prophylactic methods that may work, but they would need to do a randomized trial. So I shared that with them. I've not heard anything back on it. But when you have a risk of COVID, it used to be about a 10,000 to 1 risk. They described it in what they call micromorts, which is a micromort is 1 out of a million chance of dying in a day. And the way you figure this out is, for example, if you are giving birth, it's like 44 micromorts. I'm sorry, birth is 200 micromorts and riding a motorcycle is 44. Getting COVID last year was 10,000 micromorts. Now, it's probably around, you know, a 1% risk, but it's still about 1 out of 100 chance of dying from COVID. Now, I believe the protocol I'm giving to people has been effective. No one's been in the hospital, gotten on a ventilator, or died with these protocols. But if you look at the side effect profile of the vaccines, it's been out now for almost a year with the messenger RNA. Thrombosis and thrombocytopenia syndrome, the TTS, is 3 out of a million risk. The risk of getting myocarditis in a young person from the messenger RNA is 3.5 out of a million. The risk of getting Guillain-Barré syndrome is 7.8 out of a million. So you've got a 1 out of 100 chance of dying from COVID. And if you don't die from it, you might get long hauler syndrome with chronic congestive heart failure and lung damage and strokes. And you can still get Guillain-Barré, whether it's from the vaccines or from COVID itself. Organ damage, blood clots, increased dementia, Parkinson's risk. I mean, it's really nasty long hauler. And although my primary hypothesis is that it's glutathione deficiency, not enough antioxidants, We don't know. So you don't want to really become a long hauler. We've treated 8 or 9 long haulers with the same protocol for acute COVID, and it's worked, but those numbers don't tell me whether that protocol works. We're actually about to do a randomized trial at the University of California, Irvine, using the MSIDS model and seeing if glutathione deficiency is playing a role in long haulers. So stay tuned for that one. But if you look at the risk, of the vaccines, most of these people say, well, I want safety studies. Well, we have them now. It's anywhere between 3 to 8 out of a million of getting a side effect, but 1 out of 100 chance of dying. And if you go in the hospital, most of the doctors are not going to give you ivermectin. I've battled with hospitalists and stuff on this already. So, then the people who say, I don't trust vaccines, well, the prior vaccines, a lot of them had aluminum as an adjuvant, or thimerosal, mercury. This does not have it. It has PEG. And PEG can be removed from the body because it's a fat-soluble molecule using glutathione. The last one is, I'm not afraid of getting COVID. Well, you should be, because with the Delta variant, right, it's 10,000 times more infectious with much higher viral loads. And they're showing that it's only really the unvaccinated people. It's like 97 to 99.9% of the people in the hospitals right now are unvaccinated, and almost everybody is getting Delta. So I've suggested it to my patients, but I will tell you, my experience is about 50% of the patients flare. They get side effects from the vaccines, and some are a few days and some last weeks. But in our practice, we've only had 1 or 2 people, maybe 3 with longer term symptoms. And these are usually the people that have very active Lyme with co-infections like Babesia and Bart. And the way we block inflammation is, again, these 3 pathways, which you can look out on my website. So, I just want to point out, I'm trying to protect people's lives, right? I can get you better from Lyme, but you have to be alive. So I took the vaccine, I took the Pfizer, so did my wife. I looked at the data for months before I got the vaccine. I was not trusting it initially, but the more and more I look at the data of the Delta virus and what's happening and the side effects of the vaccines, which the CDC just released within the last week, 3 to 8 out of a million, odds are really in your favor at this point of getting the vaccine. But if you're a Lyme patient who's active, I would block NF-kappa B, use glutathione, use NAC, stimulate NRF2, curcumin, broccoli seed, take melatonin, take zinc, vitamin C. There's things you can do to lower the inflammatory response, because you know that when you get Lyme, it's due to inflammatory cytokines. When you get COVID and get a cytokine storm, it's the same inflammatory cytokines as Lyme, which is how I knew to use glut. So that's just kind of the overview I just want to start out with. If you look at the studies and what's come out, why I think the vaccines are reasonable at this point in time for the Lyme population.
Thanks, Rich. What you've articulated is what we're all doing right now is given the problems with COVID, can we prevent COVID? So there's so much information out there, and the studies are not that good. On the other hand, when you're sick, you're looking for a way to get that immune system better. And so Rich Horowitz has learned a lot over the years to try to get better control over the immune system if you have Lyme. Now, it's particularly problematic because some of my Lyme patients are so sick, having so many relapses already, they're afraid of getting a relapse. It's almost like a PTSD, post-traumatic stress disorder. And so even a modest flare-up is disturbing to them. So Rich, have you seen some people that act somewhat like a PTSD in terms of they dread COVID, but they're also particularly dread of any side effects that they might get from the vaccine?
Oh, absolutely, Dan. I think you're right on target there. I mean, many of the patients who finally got back to work and are there, they do not want to go down from having a side effect from the vaccine with flares. And again, it's interesting. Lorraine Johnson, she had done my Lyme data. I don't know, Dan, if you've looked, if she's updated it, but when she put it up, it was a few months ago, she said when I was looking at the site that the side effects in the Lyme patients were roughly the same as the general population. I personally have a difficult time believing it, because it is about 50% of my patients who are having side effects. But fortunately, as I said, most of them go away within weeks to a month, but that's with me basically blocking inflammation every which way that I've done it. So yes, I think there is a PTSD component. I think people are worried the flare will not go away. I will tell you in the past that I've had patients who've gone for vaccines, regular vaccines, Meningococcal vaccines, I'm going into college. One of them in Harvard had to drop out for a year because the side effects were so bad and his Lyme flared up. I've seen the same thing with the HPV vaccine. So I've generally, and people who know me well have known, I have not recommended vaccines to Lyme patients over the years because they do flare up, and I've seen people have to drop out of school. That doesn't mean I haven't taken vaccines. I've taken every one under the sun. But Lyme patients have overstimulated immune system. What I don't like about the prior vaccines is aluminum. It could cause autoimmune disease. They need to get the adjuvants out of those vaccines, but this is messenger RNA. Messenger RNA, when it's shuttled into the ribosomes and you're making proteins, it's destroyed within minutes. If you're going to have a reaction, it's from the PEG. It's from the molecule they're using to shuttle it in. And because it's fat soluble, you theoretically should be able to remove it with glutathione. So, the patients out there that have heard stories, we really need a controlled trial of, half the Lyme patients take 2,000 milligrams of glutathione with a half hour of the vaccine. 6 hours later, this is what I told my patients to do, repeat it the next day and block inflammation. Now, is that different than what the general community's experience is? Maybe, because they may not all be following this, but yes, Dan, I think you're absolutely right. They're scared and they're afraid of a flare that just won't go away because it has happened with prior vaccines. I've seen it myself, but not this vaccine.
Yeah, no, I took the Moderna, after waiting until every other doctor I can think of took it first. So I took a gentleman's approach, let them do it first. I probably even had Rich do it first, but I've never had Lyme, so I didn't have to worry and dread about the potential for a flare-up. Now, any one flare-up is bad for a patient, even if they hear it through a blog. But the reason for this survey is get some more data, because sometimes, even though you have to make your own individual choices as a patient, is this survey ask, what are you like if you had COVID? So you can compare it to somebody who's not had COVID, not the vaccine. But what's particularly interesting is it takes the Moderna and what were the side effects? How severe were the side effects? How long did they last? Would you recommend taking it again? And when you take the second Moderna one, what are the side effects? So, because I have patients who tolerated the first one, didn't do very well in the second, vice versa. So even though everybody has to make an individual choice, this survey pours on kind of stats that will hopefully help in decision making. It will also help physicians, because physicians are, whether you work with Lyme or not, are running into the same problems. I'm sure they're running into the same problems with other immunocompromised diseases or impaired diseases, anything related to the immune system. So if I could articulate through this study how difficult it is for some people who have an illness like Lyme to tolerate it, they might not be able to give Lyme patients so much trouble who decide not to. I think one should take the vaccine because the risk of death, the risk of major complications is such a high priority for me that it seems like that's the right thing to do. But each patient is looking at the data. Hopefully this survey will add that data that they need.
Yeah. So, in the last 2 weeks, Dan, when I was looking at the stats, the hospitalization rates have gone up 40% and death rates have gone up 18%. And it's mostly in the unvaccinated states like Arkansas, Florida, and Louisiana, right? But the death rates are going back up, and we've lost over 600,000 Americans to COVID. So, I mean, we know this is really, it's a rough virus. And I'm a bit concerned, truthfully, that some people that don't have adequate antioxidants and glutathione, they're going to have a much rougher time of it. I treated an ER doc, by the way, early on, who was on the front lines, who got a bad case of COVID pneumonia and couldn't go back to work. He was a long hauler with lung issues, and he responded to 14 days of ivermectin and high-dose glutathione. I mean, I think, unfortunately, I could never get the study done for a randomized trial at UCI, but just know that I think for prevention and treatment, I do think it's helpful, but this thing's going to be around for a while. I mean, they're talking after Delta, there may be Lambda and other ones coming along. Nobody really knows where this is going, but clearly the vast majority of the hospitalizations and death are in the unvaccinated. And I first have to keep you alive, and then I could get you better from Lyme, right? But the first step is I have to prevent death. And there are people that have died within 3 days of getting COVID with blood clots. So, and that may not be enough time to call me up on the phone and say, hey, doc, I need some ivermectin. So that's, I think, part of the problem I'm facing, that I just have to protect my patients. I don't want them to flare. I'll block inflammation, but I've got to protect them from death.
Well, that Arkansas study that you just mentioned, one of the things that was alarming was that the average age for hospitalized COVID patients was like 61 in the first wave. It's like about 41 now. And so it's for some reason, maybe because some of the elderly are vaccinated or they've cooperated with the social distancing a little better. But for it to drop to an average age of 41 means half the people by definition are younger than that. So it's hitting home to, even if you don't have Lyme disease. It's particularly important when you look at the numbers. And that's why I think this kind of discussion, with two doctors, you and I on the front line, I find the patients are on the front line also. They're in a vacuum trying to sort this out with all this myriad of facts out there.
Yeah. There's I'm looking at the chats that are going. There's actually some good questions about Lyme patients that are immunocompromised. Phyllis Freeman and I, when we published our study in Precision Medicine a couple of years ago, we found that 7% of our chronic Lyme patients had chronic variable immune deficiency. 20%, a little bit more, had low immunoglobulin G, and like 75, 80% had low subclass, like 1 and 3, which you need to fight infection. So, a lot of these patients, at least in my practice, I don't know in yours, Dan, but they are taking subcutaneous immunoglobulins. Some are on IVIG if they have small fiber neuropathy or autoimmune encephalopathy. But definitely, what I've done specifically for this population is measure their natural killer cells and T cells. So I've done CD4, CD8, natural killer cells, see if they're low. Some have been low. And I've given them 3,6 beta glucan or transfer factors, which raise natural killer cells. We put them on zinc, which helps macrophage function. Leave them on vitamin C, vitamin D, apart from those 3 pathways that I talked about that block inflammation. That, again, just go to my website, cangetbetter.com, look under the COVID tab, it's all there. So it is a big problem for immunized patients, immunocompromised, and they are saying that they're the ones specifically who are probably going to need a booster shot. Now, the only problem I have with booster shots, and this is the same problem with the flu, the Delta virus, the ones who are vaccinated are clearly not getting as sick. At this point, almost 99.9% of the cases are unvaccinated, but I'm not sure what the booster is actually going to do if you're immune compromised. And it's possible if you get antibodies, someone asked this question, the antibodies may actually, especially if it starts to now get antibodies from the general population who've had Delta, it's possible that those monoclonal antibodies they've been using may actually give some protection. So, who knows, but it is the immunocompromised patients that really, really have to pay attention here.
I want to mention boosters, because having a booster shot's in the discussion all the time. And so this survey that I encourage you all to fill out has several questions on boosters. Would you take a booster with what you know now? Would you take a booster if the initial studies are safe and effective, and if you choose not to, why? So it tries to contribute more of the Lyme disease perspective on boosters and on COVID. And so this kind of a survey will articulate everyone's voice and their concern instead of just anecdotal information. So before the day's out, if you or a friend or talk to a friend and filling out that survey, they don't have to have COVID, they don't have to have a COVID vaccine, they just have to have Lyme at some point just to get a baseline. And but I want to go back for a second to something you mentioned at the beginning, Dr. Horowitz, on timing, because you have this illness that isn't going away. It's been around for 1.5 years. It's not going away, plus the Delta. So if one wants to do preventive measures, it's like a lot of months. And then if you decide, well, I'm sick now, is how often should you jump into preventive measures? And then when you're past it, how long to stay on it? It's like, it's a never-ending series of questions as to what's the right time and who should benefit. Are those with vascular issues? Are those with certain type of issues ones we should target? But it's just more of the timing. Or is there a way to time it such a way to make the best use of these treatments?
It's a tough call. I read the studies by Corey a while ago, and there are basically at this point 18 randomized trials on ivermectin, and they have shown some prevention studies that have shown that it's helpful. And one of the in the chats, one person was asking, why aren't doctors then prescribing this? Part of it is because I think the FDA and the NIH have not yet said that it's okay. They're kind of sitting on the fence on it. But I will tell you that I think it's more a problem of medical politics with big pharma kind of controlling the dialogue than it is actually medical science. So personally, I took the vaccine, both ones, and I'm on ivermectin prophylactically twice a week, and I'm doing NAC, Alamax, and Glut. I do not want to get this virus. I think it's one of the nastiest things that's come along for a while. We don't have all the answers on long haulers at this point. I mean, these people are coming down with congestive heart failure and lung scarring and strokes and increased dementia, POTS, just like you get with Lyme. You don't want to get another chronic fatiguing illness on top of what you've got. And although I think what I'm doing would be helpful, I don't have the proof. Nobody has the proof at this point for long haulers exactly what's going to do it. So I think you just kind of consider all this. And someone in the chat was asking, some physicians in the Midwest are not treating, and they're saying that don't get the vaccine. So what every person needs to do, and Dan is the perfect person for this, Dan has a master's in public health and looks at statistics. He looks at data. He doesn't look at, I hear this, I hear that. You've got to look at the solid data. And if you go to the CDC site, they've just published in the last week the data on whether pregnant women should go and get the vaccine. They basically said yes, because otherwise there's risks of miscarriages. And of course, pregnant women getting very sick and ending up in the hospital. They now have the studies that unvaccinated people have a 2.34 increased risk of getting it again if you've not been vaccinated. I just think the statistics are there. And 1 out of 100 deaths from COVID and having a side effects that's between 3 out of a million to 8 out of a million of a clot, myocarditis, or Guillain-Barré. You get in your car every day to drive to work. You've got more of a risk than, honestly, probably taking the vaccine when you look at that statistic. So I don't know, doctors say whatever they say. They probably see flare-ups in Lyme patients and say, don't do it. But you have to prevent people from dying first. And we don't yet have answers for long haulers. Again, I think it's glutathione deficiency. We'll look if the randomized trial does it, but the statistics are there. This has been out for over a year. I don't think with VAERS, with the vaccine adverse event reporting, most of the prior vaccines, they might have looked out maybe 4 weeks. They've been following this really carefully. They've had to, much more carefully than any vaccine that has ever been released. And by the way, a month before the J&J came out, I told people that I didn't like the technology with the adenovirus because I don't want people getting DNA in their nucleus, which could cause an overstimulated immune system. But the messenger RNA, it's destroyed within minutes. So once it gets into the ribosomes, it's not there anymore. It should not be affecting your genome. There's a possibility I heard from scientists. What about it's retroviruses and it turns it back into DNA? Well, nobody's proven that. It's a hypothesis. And we know that the vaccines are stopping death. They're stopping hospitalizations. And the Delta, it's looking worse and worse with the death rates going up by 18%. So I think, having dealt with Herxheimer reactions in Lyme patients for 30 years, there's ways to do this. You alkalize the body. You take high-dose glutathione, 2,000 milligrams up to 3 times per day. I've got all of this on my sites. It's in my books. There are ways of blocking inflammation, but you've got to be alive to be able to help yourself and get over Lyme and the co-infections. And that, I think the statistics are actually quite clear. And I think at this point, it's fear for, I think, Dan, you probably hit it. It's more PTSD of, I can't take a Lyme flare. I can't be out of work. What if it doesn't go away? I think you're probably right on target with it because the statistics say it's much safer to take the vaccine than to get COVID at this point.
Well, Rich, you're talking about COVID long haulers. And so I think we've learned a lot from the Lyme disease community that we're all downplayed. There's just everybody minimalized what happened to Lyme. They still have a number of doctors who refuse to consider that there is such thing as chronic Lyme, and they refuse to think that Lyme is nothing more than aches and pains of living. So one thing that's important is that, you know, there's so much attention to death. So I think some people say, oh, I could die, and well, if I'm dead, I'm dead. You know, that's the way it goes. But a lot of people end up with respiratory issues, kidney issues, long-term cardiac. But what we've learned from the Lyme disease community is that there can be a huge number of people with chronic illnesses. So even though they say, oh, that's long hauler, and they say it just like, you know, chronic fatigue, fibromyalgia, and they say Lyme is like, it's all, they imply they're all psychiatric issues, is I can see, and I can see the writing on the wall that these patients are easily going to dismissed unless there's some oversight as nothing but a fictional psychiatric illness. And so that is, I keep piping on the clinical, on the trial, the survey I'm doing, because I'm hoping to not only do a cross section, but follow these people over time. Because if I can catch some people who are healthy with their Lyme, or at least relatively healthy, or aren't having any issues, and they get COVID, or they take the vaccine, if I already know their story before they get it, I can have a better sense of what happens to an individual before, during, and after with this service. Just a little bit fancier design. By the way, I'm happy to announce that I have 430 people who already completed the survey, and my statistician says 430 is a great start, and there's so much statistics that I can do with that. And he's excited because he's working with me to prepare for the ILADS meeting in October, because I can start not just collecting data, but I can start laying out the data and presenting what the findings are, so we can get the feedback now, not some future time.
No, that's great, Dan. I'm waiting to see that. And you brought up a good point, by the way, about long COVID and chronic Lyme. They really look quite similar. Fatigue, body aches, headaches, neuropsychiatric symptoms, insomnia, POTS, right? It's very similar, but I will point out that one of the big differences between Lyme and chronic Lyme and long COVID is the migratory pain aspect that you get with Lyme that you will not get with COVID. So in Lyme, up to 95% are going to get migratory joint pain, migratory muscle pain, or migratory nerve pain with tingling, numbness, burning, or stabbing, and you don't get that with COVID. And with long hauler, with COVID, you can get heart damage, lung scarring, seizures, strokes, blood clots. You don't normally see that with Lyme unless you're dealing with like a really horrible case of Bartonella with transverse myelitis, or a Powassan virus case. So the serious long-term effects are definitely different in that population. You don't usually see it in the Lyme patients.
Have found is that when even though most of the tension from medicine is on the organ failure, organ problems, is that when you look at the epidemiology type studies that are published, is that the dominant problem is the cognitive problems, the neuropsych problems, the fatigue. And so, we're talking about 25, 30% sometimes at least have those issues. So hopefully the leadership in the Lyme community will not let those patients slide. We also want to make sure they don't overlook the fact that some of them have Lyme. So I think we're going to be charged with trying to better identify what kind of patients that we're dealing with. This survey is supposed to look at, well, what is the actual numbers out there in trouble? And hopefully a survey like that will be done in those who don't have Lyme, but maybe have some of these other things like chronic fatigue, to better understand the morbidity. Because people, I told you, don't worry about death. They should really be worrying about living with a chronic illness.
Yeah, no, it's a very good point. By the way, I keep reading the chat so I can answer some of the questions along the way. Someone had asked, are Lyme patients showing antibody responses? I'm seeing antibody responses, but if you're one of these people, again, that has low immunoglobulins and does not respond, let's say, to a pneumococcal vaccine, which, by the way, I do give to Lyme patients. Those are safe. There's nothing active. It's just the capsules of pneumococcus. That's how you can test if somebody actually's immune system is working correctly. The Lyme patients that don't have a pneumococcal response, those are not going to normally have good antibody responses to a COVID vaccine or to getting COVID. But I test people intermittently. I'm getting back positives. But if you look at the antibody reliability testing for COVID, it looks about as good as Lyme. They claim that it's higher, but I've definitely seen problems with it. A couple of the questions that came in, which kind of overlap, is the supplements prior to taking the vaccine, how much glutathione? So I usually use 2,000 milligrams of liposomal glutathione 1/2 hour after the vaccine to pull out the peg, 6 hours later, and I repeat it the next day. But these patients are on NAC, alpha lipoic acid, all the things I talked about that just look at the website. And you probably want to be on zinc and vitamin C and curcumin and broccoli seed probably for a couple of weeks before, because there are 3 major inflammatory pathways you want to shut down. NF-kappa B is shut down with NAC, alpha lipoic acid, glutathione. NRF2 stimulation, which lowers inflammation, is with curcumin, broccoli seed extract, green tea extract, resveratrol. The NLRP3 inflammasome pathway is shut down by melatonin. So if then you add in zinc and vitamin C, and this is what I was recommending early on, none of my patients got very ill. They got COVID, of course, but they did not get severely ill. I had a couple that were very ill, by the way, but most of them were not severely ill getting COVID, and they all responded to the ivermectin glutathione protocol. So I would be on these things for at least a couple of weeks, and that's the dose. And as far as people who have MTHFR or autoimmune diseases and the rest, there's been studies published at this point, even for people with lupus and rheumatoid arthritis. They're finding the benefits are outweighing the risk, because when you look at the inflammatory cytokines that come out from COVID, they happen to be the same as the ones you get from Lyme. So if you have Lyme and COVID, it's like pouring gasoline on the fire. And that's why you want to kind of knock this down. I don't think someone asked about people with ME, myalgic encephalomyelitis. I haven't seen any studies of like how well or not well people do with the vaccine. And of course, I think CFS-ME, there may be a lot of reasons why people get a chronic fatiguing musculoskeletal neuropsychiatric illness. Lyme MSIDS is, of course, what I recommend looking at first, because it could, of course, be viruses and other things. But I think all in all, when you look at the data and all of the stuff that's been published, and I've been following it, I'm probably reading the literature at least 2 hours a day. I mean, it's burning me out at this point, trying to keep up with all the COVID literature and Lyme literature and climate change literature. It's a lot every day. But I think the overwhelming statistics at this point is that the vaccines are extremely safe, and you can block inflammation after a vaccine. Now, again, unless you did it the way Dan did it, and we had 300 Lyme patients take the vaccine without those protocols I'm describing to you, and 300 who do it, I really can't tell you what it's going to be. But the job as a physician is always to keep you alive. And once you're alive, we can figure out how to get you better. And as I said, I've only had 1 or 2 people who have chronic symptoms after getting the vaccine. 1 or 2 out of most of my patient population has gotten vaccinated. I've sent out blasts to my patients to do it. Someone actually just put on the post, I'm an RN in the front lines. I followed your tier 1 and 2 tier the entire time and never got sick. That's great. I do think for those of you who are listening to all this, that the vaccines are preventing death. It's a 1 out of 100 shot of dying. The side effects should be 3 out of 1 million, 8 out of 1 million. There's long hauler, everything that you could get. If you're still not going to do it, please consider taking prophylactic ivermectin and these other supplements, because I believe from all the literature I've looked at, it will protect you. And I, again, told this to HHS. I'm not shocked I didn't get a response, but I'm sharing the information just to see if they would like to do a randomized trial and prove it, because there is a certain percentage of our population that is just not going to take the vaccine. And this is probably the most well-studied vaccine that has ever taken place at this point in time. And I like that it doesn't have adjuvants like aluminum or mercury. And that's the reason why I have not told Lyme patients to get vaccinated before, except maybe tetanus pneumococcus. But I would rather you get Tamiflu for 5 days for a flu. I mean, I'm sorry, I don't recommend vaccines, but this is death or life. It's a different story. That's where I'm coming from as far as my recommendations.
So Rich, one thing is that I just posted where that one could get to my website to find the link for the survey, but if they need to communicate, because I know you're going to post some things, if they need to communicate, do you have like a website you want to put in the comment section, or some other way to communicate with you?
Well, my medical website is cangetbetter.com, but I don't usually communicate. If somebody really has a question for me that wasn't answered tonight, just do it through the medical email at my office, which is medical@hvhac.com. It stands for Hudson Valley Healing Arts Center. You better just sending me over a question there and I'll get it answered for you.
Yeah, thanks, because it's we're only beginning to address some of the questions. There's so many things to talk about. We're missing quite a few of the comments on the right side. So I'm glad you're picking up what you can as you go along. So, I want to keep talking. I want to like set some kind of limit as to, because we can go forever, as long as this is going on. So I was thinking that maybe we should maybe close in like 10, 15 minutes. How does that sound to you?
That sounds fine.
Yeah, so it's what other things that you'd like to cover, Rich? Because I thought that I didn't want to overlook some things you like to.
No, I mean, I'll just answer some of the questions there. People who cannot tolerate gluten NAC, there is a different type of a precursor of glutathione. It's called, I believe it's called Continual G. It's available online. I learned about it from the people in New Zealand who produced it. Some of my Lyme patients really like it. It's different than taking NAC as a precursor of glutathione. And alpha lipoic acid, by the way, regenerates glutathione by 30%. If you still can't take Continual G, whey-based protein, which contains sulfa groups, is a way to get that in, and that will help boost your own glutathione production. You don't need high dose glutathione. 2,000 milligrams does not require an RX. Glutathione is over the counter. You can get liposomal from many different sites. Research Nutritionals has them, other ones have them. How does the vaccine protect from long COVID or permanent damage? Well, the main thing is that the vaccine basically is showing that in people who get Delta at this point, they're just not getting nearly as sick. And by the way, I have now treated a few people who were vaccinated and got Delta. And it was very interesting because early on, 88% were getting anosmia, they couldn't smell, parosmia, strange smells, dysgeusia, I can't taste anything. This new Delta virus, it's not acting the same way. It's acting kind of like old viruses where you get stuffy nose and you can't breathe through your nose from stuffiness or sneezing. It's more like regular viruses. So it has changed a little bit with some of the early symptoms that we saw. But clearly, the people are just not getting as sick after they get the vaccine. So I can tell you right now from looking at the stats, I looked at the CDC site this morning. They had 3 studies they just published in the last week on pregnancy. One of the actual side effects of the vaccine, which, as I said, is 3 out of a million TTS, up to almost 8 out of a million Guillain-Barré, 3.5 myocarditis, and that over 97% of the people now going into the hospital with Delta are unvaccinated, and this death rate has gone up 18%, and it's almost all of these cases are unvaccinated. So it is protecting people from getting sick. How much long COVID? I haven't seen a data yet on the vaccinated, but it would make sense that it's not going to be quite as frequent, but I've seen a couple of POTS cases in people who came in with long COVID from other practices, so I think the best you can do is look at the statistics and say that's the best you can do at this point in time. If everything we've talked about, you still have hesitancy, then look at the website and look at the other prevention protocols that you can do.
Oh yeah, Rich, I can mention that. Even though we talk about death or organ problems, is that it's, people have been writing to my blog because I write about hesitancy, write about everybody's concerns. And so, whenever you see blogs, they often are echoing what they're observing out there. But it's not like I'm seeing any deaths or hearing about deaths in my practice. I'm not seeing any organ failures or organ problems. I've seen some people with some pretty persistent respiratory issues. And so it's not like my Lyme patients, that I've been in practice for 34 years. So it's not like they're dropping like flies. In fact, that for some odd reason, they're not in death or organ failure. It may be because they just have an impaired immune system rather than the traditional immunosuppression. But I think that my main concern is that, and what most of my patients' concern is, they don't want to suffer, they don't want to need to suffer, they want to relapse, they don't want to end up in more chronic issues. And that's really where you and I have been talking about for a long time, is that's an important group.
One of the, on the chat, someone is saying that you're recommending the vaccines for active Lyme, co-infections, EBV, and for those who've had COVID with antibodies. Now, those are two separate questions, and it's a good question. The answer is I am recommending the vaccine for, everyone at this point in my practice that has Lyme. And by the way, everyone in my practice has co-infections. Nobody has straight Lyme. But the ones who've had COVID, who has antibodies, the CDC is recommending getting a booster. Now, I follow the antibody titers in some of these patients, and they're still good. And what they're saying on the vaccine is the efficacy is waning over time. Like by a year out, it's not quite as efficacious. So, but my problem with the booster is if the Delta is significantly different, I just don't know. That's like getting a booster flu shot when the flu is the next strain from the next year. I'm not quite sure how well it's going to work yet. And I think they've really got to work on that. But the people that have good, strong COVID antibodies that have active Lyme, I'm letting them know they can hold off if they want. If you've got antibodies, hey, take ivermectin twice a week with some NAC alpha lipoic acid glutathione. It's fine. For those people that really have fear and already have antibodies, no, there are other preventative measures that you could do. But for those who have no antibodies or are immune suppressed, those are the ones I think you've got to be careful with.
Yeah, Rich, one of the problems that doctors have in New York, and I mean, you're in New York, but one of the challenges is that there's so much anti-government, or at least government, but besides anti-government, there's plenty of government forces going on of don't take something until they've had a randomized clinical trial. Don't take something if it's talked about in the media, it must not be good. And so, New York has is not the only place in the world where there's pushback by the medical establishment. And so sometimes we end up with this challenge as a doctor. I find it challenging myself. I can do a lot of things, but there's a difficulty of doing some of these protocols in New York State.
Yeah, I mean, sometimes the pharmacists have given me trouble with ivermectin. They've asked why I'm prescribing it. UO 7.1, and I'll give you the randomized trials if you want it. I'm holding on to Pierre Corey's, the Frontline Alliance Against COVID with Corey. I mean, they've done a great job of putting together the randomized trials for ivermectin. And again, when Phyllis Freeman and I published 2 articles last year, one was in Medical Hypothesis, one in the Journal of Respiratory Medicine Case Reports with Glut. The one that I did in Medical Hypothesis with Phyllis, we talked about ivermectin. The early studies showed that it lowered the viral load by 5,000-fold. Now, I don't think anybody has the data on Delta, and somebody actually should do it, but so far it's actually held up extremely well, and it's medical politics. That is not medical science. So I'm vaccinated, I'm on ivermectin twice a week, and I've offered it to my patients. I sent them out a blast and said, if you're worried about Delta, whether you're vaccinated or unvaccinated, ivermectin is a safe drug. It's been shown to be efficacious in studies through Dr. Corey. You can look up Pierre Corey, K-O-R-Y, Frontline Alliance for COVID. Just look it up. The randomized trials are there. I think it's not an unreasonable approach with Delta. And I'm taking every precaution I can, which is getting vaccinated and doing that to make sure I don't get it. This is the trickiest, infectious disease I've seen come along in quite a while. And somebody asked about what am I advising for long COVID with respiratory. The doctor in the front line who had COVID pneumonia responded within 14 days of ivermectin, 0.2 milligrams per kilo once a day with 2,000 of glutathione 3 times per day, 600 of NAC, 2 of them twice a day. It's all on my website. I just gave it to you on the chat, cangetbetter.com. Look under COVID, it's all there. And the respiratory issues, by the way, there is 140 times more glutathione in alveolar lung tissue than any other site in your body. And every risk factor they found for COVID-19, diabetes, people with congestive heart failure, strokes, they found in the literature that low glutathione was one of the common denominators found in that group. So I believe that these people with severe lung problems, they're probably glutathione deficient because they didn't have adequate antioxidants. And JAMA just published today, I just saw it out today, that the medications that lower interleukin-6 will decrease mortality. Well, guess what lowers interleukin-6? Blocking NF-kappa B. When glutathione goes down, IL-6 goes up. NF-kappa B, when you stimulate NF-kappa B, you get IL-1, IL-6, IL-8, IL-10. It causes these inflammatory cytokines to come out. So glutathione, NAC, and alpha-lipoic acid block NF-kappa B. And according to the study in JAMA, theoretically, and this has been published, taking these should prevent morbidity and mortality. But again, we just don't have a large enough trial. But JAMA did say if you lower IL-6, the mortality rates are going to be less.
So Rich, one of the things this database offers is that it asks if you've taken supplements, if you've taken alternative, if you've taken ivermectin, or if any of these things, even if they're not listed. So hopefully it will give you a little bit of a snapshot as to what they're doing. So you and I should spend some time looking at any extra information, because some of your patients that have seen you or followed you or got to know you are taking these treatments, and my patients are taking a lot of treatment. So you and I will have to sit down and figure out what can we learn from it. We also can, because it's a longitudinal study, we can look at what happens over time. And lastly, because I am asking not only where are you now as a Lyme patient, but are you willing to be contacted for future studies? So it's possible that if I have a database of people who have been really helpful in filling out the survey, they may be willing to answer some of the questions that we didn't answer today. And so hopefully you and I can put our heads together.
Sure. One last thing I want to say about someone who's asking about cytokine panels and the rest. They did studies in the ICU in patients who were hospitalized with COVID, and they found low glutathione, by the way, as being one of those markers that was showing up in the people in the ICU. They just have not done the opposite study, which is check glutathione levels in the general population, especially in people that are immune suppressed, et cetera, and see what role that's playing. But you know, the links are kind of coming together, and I'm surprised nobody's looked at this. I've had more hits. Phyllis and I have had more hits on this glutathione article. I think it's been cited over 100 times. I've not had one Lyme article in my lifetime be cited over 100 times in 1 year. Every 4 days, this article is being cited, and it was 2 case studies. Now, I've treated over 100 with the protocol, and it's worked for everybody, but I'm just surprised that the government or anyone has not looked at the biochemical pathways. And of course, again, I think it's just because the dialogue is from Big Pharma. Merck, you know, ivermectin is off patent for Merck for a long time, and I think they're restricting the dialogue. I think there's no coincidence with this, and it's a terrible thing, which is why you may know me as Prince Ian of Arcturus. I have no filter between my brain and my mouth, which is why I write to the FDA and I write to HHS and I tell them, you may want to look at this. I think this is helpful. I wish somebody would get back to me someday, but I'm sharing my opinions and telling them what I think would work in people who refuse to get vaccinated, people who are in the hospital. I don't know what they do with this information, but I'm sharing it as best I can.
Okay, well, what I'd like to do